All right. Can you go back one? Hit the green. There you go. Perfect. Thanks. Hi, everybody. Thank you so much for coming out. My name's Devin.
I am Susie.
And we're very pleased to have you here today. We are going to lay out some problems, some challenges, and then hopefully talk about a solution and then show you a really cool, fun video. So let's get started.
Yeah. So I'm going to tell you how I ended up here with Devin. And that is in about 2010, a developer came to Boise State University as a trailing spouse with his wife. And he got one of the first pairs of Oculus Rift glasses. And he came to me and said, if you could build anything you wanted to build for healthcare, what would you build? And I said, we seem to really have a problem with teaching nurses sterile technique these days. So if it was me, I would build a Foley catheter insertion game. And he said, well, let's just do that. So we did. We won a Western Regional award for the best use of technology for education and things like that. And then Mark Zuckerberg bought the company, Oculus Rift, and locked it down for 2 years. So we were, stopped in our tracks. And I moved on to other places. And I've just happened to bump into Devin, and we've been kind of talking back and forth and doing new things now. So I have a little bit of knowledge, much more on the healthcare side. Devin swings both ways in education and in the VR world. So
yes, this is actually part of the reason how I looped and wrangled Susie into coming back this year. Last year, I did a talk on the WHO, the World Health Organization. There is a major shortfall in healthcare coming, 10 million in 6 years. And I reached out to Susie and said, hey, I've been invited back to speak at AWE again. Would you want to join me? And we'll talk about this nursing challenge that we're going to show you today about student safety.
Absolutely. And so what I see from my world is that in the hospital environment today, everybody believes that clinical in the hospital is the way to go, except that when you're in the hospital today, in the case of nurses, a lot of times we're only allowed to observe. We're not allowed to touch the patients. I'm not kidding. And then when we graduate, they expect us to arise as Venus, fully formed out of the school and be ready to participate in everything that's going on. It doesn't work that way. So VR is a big help in this area. A lot of times the providers that we're working with in the hospital, their skills are actually weak or not conforming to what we know are best practices, and they are supervising our students. So we get you taught us here, but we're seeing this in the hospital, and we say, forget what you see in the hospital. We're teaching you the correct way here. We don't want infections. We don't want these kinds of things happening. And then first among equals, we hope that, and I don't know what I'm thinking about when I say that, so I'm going to skip it.
Well, Susie, how could this be possible with all these students? They get to touch plastic mannequins and rubber skin and all this stuff in sim. So how could they not be so prepared for the real world environment?
Because we have nurses who actually have to try to teach with these things, and they do not practice very well themselves. They don't know how to use the technology. They're not necessarily great educators. So let me continue on down my little list here. So learner vulnerability in the sim. The other thing you have to think about is that when you're practicing with a big plastic mannequin, and these are anywhere from $10,000 for the static ones up to $250,000, it used to be.
And 190 pounds, 250 pounds.
Absolutely,
very, very
huge things. What was I going to say here? You're practicing, we're doing it in front of you, everybody. Now we're behind glass, but you know you're being observed. And what I want you to think about is every time you go into the bathroom, if I had to stand there and watch every move you make and heard everything that was going on, wouldn't that kind of intimidate you and make you afraid, create anxiety for you? This happens for our students. So it is what we've got now to substitute and provide more clinical education for our students, but it is not completely ideal. And what we found out, and the other big organization where I go is the International Meeting of the Society for Simulation in Healthcare. And what we know in the medical world is that we did a lot. 10 years ago, there used to be debates over should you kill the mannequin or not. And it was funny, ha ha. until they started having their own physician students, their medical students, leaving school because they felt so terrible that they had killed a mannequin during a simulation. So then we've learned a lot along the way about how best to teach with this. Happened really dramatically in medical school, but in nursing it's the same thing. In mental health, we know that 40% of today's undergraduate students are on anti-anxiety medications. And a large number of them are being treated for clinical depression while they're in school. They've also been rewarded for taking a test and getting an A. It's really fun to have students in simulations say, I guess the A I got on the test last week doesn't make a difference if I can't apply the knowledge here in the clinical space. And we say that is correct. This is a practice discipline that applies knowledge. It's not just taking a test. And what we know is that we have a lot of untrained faculty. Thank goodness, in both medicine and nursing, there are a lot of people who have to die or retire before things are going to get better. And we have now a lot of new people coming in, but school has not really had a great uptake on using some of our coursework to teach us how to teach with simulation, or VR for sure.
Well, let me ask you a question on that. You said we have untrained faculty, but we're hiring, we as in the education institutions, they're hiring nurses from the field, especially post-COVID, right? And nursing shortage. So they have a faculty shortage, so they hire a professional. Well, that's a trained person, isn't it?
It's a very great clinician who has usually not had any courses in education. We are expected now by one of our major nursing accreditation bodies to go take continuing education to learn how to teach. And yet simulation in itself is becoming a whole different sub-discipline in healthcare. It's absolutely crazy. The system is really messed up. So not everyone who wants to teach should be teaching. The thing that we find in that I didn't know is I was a clinical instructor for years, how often I was saving the patient from the student because I'm standing right next to a live patient and I would have to step in to say do this or that or the other thing. And I wasn't as aware of it as I was when I finally started using mannequin-based simulation, was on the other side of the glass, and I could see what my best students were doing when I probably wasn't around to see it. It's horrifying. I'm so glad I was on the other side of the glass. And sometimes when you come into the debriefing after that, people are pretty upset. And what we hear is, I taught you that last week in lecture. Can't you apply? And the answer is, no, we can't. We don't know enough yet. So this is why simulation and what we do we're going to talk about VR in a second, is awesome. So I think I've covered all of mine. Oh, that frustration sometimes turns into abuse. The other thing we have is that the healthcare system is kind of broken right now. And we have nurses, educators who will say, I'm toughening them up for what's going to happen to them when they get out. The nurses eat their young is still alive and well. So we want to try to negate that as much as we can. And part of the answer, I think, is in VR. Let me hand this over to you.
So thank you. So, and I kind of want to touch on this abuse and simulation, because that was actually a surprise to me. And the idea of abuse and simulation is really making the student feel like they're having some sort of mental abuse when they're trying their hardest to do something, and they are super fresh. Now, this, being able to gamify professional simulation is valuable. It's valuable for engagement and retention and allowing people to really feel like they're in it. But it's a serious thing. It's potentially one day do or die for the patient themselves. So we have to pretend that the mannequin is real. That causes a lot of anxiety on top of a potentially very, very good, we'll say, critical care nurse who just came out of the field, but they're not a trained faculty member, bearing down on them and pulling the rug out from under them, being able to just change what happens in the simulation in the middle of the sim, and it wasn't a part of the pre-briefing. So one of the examples might be, it's a mannequin, it's very complex, it's filled with fluids, it's electric, and it's got like an iPad attached to it, and you can adjust things, and something goes wrong. And the mannequin stops working properly, and that person who's not that trained educator gets frustrated and goes, you know what, I'm just going to code the patient. And suddenly, the patient dies. And they're bearing down on the student who's like, what's going on? And everyone's watching. And then we're seeing students drop out. And we just talked about the nursing shortage.
If we get them in, we want to get them out the other side,
Yeah.
prepared and ready to go.
So I think actually this one might be yours as well.
Yes, it is. It is. Oh,
So we're
hold
going
it
to
there.
break down the anatomy of an abusive simulation.
So this is not, I hate to say it, as uncommon as I'd like it to be. And what we see is that, and the learners have been pre-briefed, and what we find sometimes is that the learners really are not ready. They maybe didn't prepare as well as we would have liked them to. They may not have been told the objectives by the educator. They don't necessarily know what is supposed to be happening during this simulation. They don't remember the equipment. In some of our programs, people are using simulation maybe once or twice a semester. And these a lot of times are young students, and they're having their other outside activities. They're in all these other classes. Their heads are full. The cognitive load is enormous. And we think they can remember from 1 minute literally to the next. I told you this weeks ago. How come you don't remember how the mannequin works today? So if they're not coming in every week, they need to be refreshed and recommitted, reorganized into everything that they're trying to do when they come in that first time or before they go in to take care of a patient. And they don't necessarily review the drugs ahead of time. So we always talk about the 5 rights, and they need to be taking care of all of these things as they would in the hospital in the simulation area, which is in lieu of traditional clinical as we know it. So then the faculty are not prepared. Sometimes we think the students are doing too well. I've actually know of a scenario where the educator said they're doing way too well, and so all of a sudden the patient started speaking only Spanish. Why would we do something like that? The students were very confused, and things did not go well after that, but the educator felt satisfied that this was going on so that she could confuse them enough and see if they could really function under pressure, but they don't really need that. They're not prepared with medication doses. Students, a lot of times, really have trouble working the pumps.
Sure.
And
they're all different.
Every single one, a lot of times, are very, very different. They're very complicated, and a lot of people don't just have one medication hanging a day. They have 5 or 6. It can be pretty intense. And so we've had to improvise, what does that mean? Improvise disasters with equipment.
Yeah, so like when there's a disaster in the sim, you start bringing in equipment that may not necessarily be for the
if somebody's having a code, sometimes people have to run out into the hallway and drag a cart in. So can they even remember where it is? Do they remember, have they ever opened a cart? In the hospital situation, sometimes students are allowed to open up and look in a real crash cart, but a lot of times they're not. So if they're actually in a situation like that, the first time they're seeing the real thing is in a live crash situation. It's not a good thing.
Right.
And then faculty leak. Some of us come into teaching with a lot of baggage ourselves, and things that we heard in the past, maybe the way we were talked to, that is the way I've learned how to teach. And I might leak out onto my students. I might say things without really meaning to, the best of intentions, but sometimes I might say some pretty cutting things, some things that do not help the students. Remember, we've got students today who got a trophy for showing up. They've always been perfect. Everything's always wonderful. They're the best of the best. And a lot of times to get into nursing school today is just as hard as getting into medical school. So when they're there, they're used to being really good at what they do. And what they find is now, first among equals, the sorting hat from Harry Potter is on, and they're trying to figure out where the pecking order is now in school. Learners can become very defensive, and it becomes our fault as educators, and sometimes it really is our fault. The culture of simulation then becomes tarnished. When they know they're going into sim, if they've had bad experiences while they're in school, they think, oh gosh, I'm so thankful it's over. I'm going into my real job now in a hospital. And they start orienting, and they find out they're going to be in simulation again. People are terrified. And they have reactions. They're getting, hives. They're getting blushed. Their necks are blotchy with different colors and things. They're sweating. They're diaphoretic. They're having actually a horrible stress reaction.
These are the nurses.
These are going to take care of you soon.
Yeah.
So we have to sometimes take them down and calm them down and redo some of the things that we've done to our to our new nurses through bad practices during school. And what we say, SIM is a safe space. I wrote an article and I said, there's no other place I've ever been where somebody looks at me and says, this is a safe space. And I'm thinking, what do you mean? If you're saying that, then what else is not safe? Why would you even say that? So sometimes we say it and then we stab them in the back. So it's not a good thing. Take it away.
Yeah, and have you ever heard the saying you're 50% as effective in an emergency? And so you practice the fundamentals over and over and over, and you develop a muscle memory so you can hit the target when you need to. And that is, what we're describing here is not what is happening, right? That is at the fundamental stage, hammering them with the emergency. And say, well, wait, let them build the foundation, the muscle memory, the clinical decision, so when they're in the emergency, they know to reach for the thing or to make that decision with a real live person. Oh, this one's yours. You don't know how bad it is. Have we told you enough?
We've already told you enough about how bad it is. Go on. Okay. 33% of people working in simulation still are not trained. And we know that the National Council of State Boards of Nursing has done a survey about every 4 years since a big study was done about 10 years ago. And still people are doing this with no training. So I'm making it up as I go along with this room full of students. So
this one is shocking. This is from the NIH. 57%, more than half of the nursing students that graduate and become professionals are not just quitting their job, they're leaving the profession after their second year, going on to do completely different things.
Right, and this is because we have not really prepared them well with our education system and a lot of times with our onboarding. And what we know is that the biggest complaint today seems to be interruption management. Is that a lot of times we've taught them in school and there are no clanging and banging, there are no calls over the radios on the outside. It's quiet, they're managing a patient, all is well. Nobody's interrupting them.
Yeah.
When they get out into the real world, there are families, there's extra noise, ambient noise, there's all kinds of other stuff going on. The family's coming up. Have you ever done this before? It looks like you're pretty new. Your hands are shaking. Why are your hands shaking when you're trying to do this? And this is creating big problems for them, and they know that this is a dangerous situation. So anybody with common sense would probably think, maybe I'm really not cut out for this. So
when I was working in the hospital, to avoid my hand from shaking when I was doing IVs, I was a hospital medic in the emergency department. And I went into the break room, not the break room, the storage room where all of the supplies were, and there was like a crash cart in there that wasn't being used. And I would set up an oxygen tube and like 5 IV needles, and I would stab the oxygen tube until the needle got dull, and I would throw it away and I'd do it again. And I must have stabbed it thousands of times because I was trying to get the muscle memory down. Because missing the vein and missing that clinical skill, that clinical decision in the moment is really hard, and you don't want to do that.
exactly.
All right, so have you guys ever seen flopping?
Okay.
So have you ever seen any of these shows? Grey's Anatomy. I really like the Good Doctor. Every single one of these shows, every day is an emergency. Okay, it's weird stuff, and I've seen some weird stuff in the emergency department. You get some X-rays and you go, "How'd that get in there?" But this isn't real life. Like, when these crazy, insane things happen, it's once in a while.
And as a nurse, I'm waiting for all the doctors to look like the doctors that were the movie stars here.
Yeah, right?
They're few and far between, trust me.
Yeah, I wasn't working with City of Angels, that's for sure. So, this is what it looks like in a hospital. You got a guy, and he's trying to figure out the call light, and the nurses are helping him while they're trying to treat him, and maybe they have to clean him, and there's family, or there's other people in there, and they're on their phone, and they're waiting for their orders, and the nurses are busy, and what do you hear all the time in the hospital, whether you're in the ICU or you're in the emergency department? You hear beep, 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 pumps going on.
You're hoping.
Yeah.
You're hoping.
And there are rules. Things need to be quiet because patients also need to get rest. So it's not always insane. It's not an emergency all the time, even in the emergency department. When I was working in the emergency department at the second busiest hospital and second busiest emergency department in the state of Arizona, we had 2 code rooms. And a code is when someone dies and you got to bring them back to life. 2. The rest of the emergency department was all the other step-down units. Mm-hmm. This is what decades of simulation has looked like. I actually had this at 50 years, but I think it's more than that, and I couldn't remember the actual number. So there's that simple mannequin on the left, and this is like the advanced super mannequin on the right. And you see that there's a person there with a computer screen, iPad thing, and they are controlling the mannequin. They are changing the vitals. They are pulling the rug out from underneath the people in real time. Now, they may have a really solid pre-brief, and maybe they're just going to stick to the script and allow things to happen. But this is the window where things are going wrong, where abuse is happening, where they're going, okay, kill him. It's 2024. There's a better way. Mm-hmm. We should be able to train these people in a standardized way, the nurses and the students. It should be asynchronous, safe, and standardized. Standardized meaning that all the faculty have access to the same standardized simulations for the institution. So all of the students are on track with the same curriculum and syllabus, that the faculty are on track, whether you're new or not. And the mannequin can't teach the faculty how to do the sim. They can't talk. You can't asynchronously have the mannequin teach you how to use it, but you can in an immersive world. Same thing for the student. It teaches the student how to navigate the sim.
Let me jump in there and say the standardization too then is controlled if you're in VR, because it's harder to change it in real time. So this is standardized, and students are alone. They have their little headsets on, and I can't bother them.
Yeah, so there are many different ways you can do multiplayer in VR sim, and we're making a really strong case for allowing that to be asynchronous and siloed. So that simulation, you can't change it. You can't pull the rug out from underneath the student. You give them a safe learning environment. They get the opportunity to finish it from beginning to end and make the mistakes and then try again. But allow the mistakes to continue. Allow them to get to the end of the story. They have predefined objectives. That's power for the educator when the objectives are predefined, when they know what is going to happen because maybe they've designed it that way. And remote deployment means scalable. We just talked about the nursing shortage. We talked about how many students and how many challenges. On a mannequin, you might have 4 people that are learners around a mannequin, but really only 2 of them are getting anything out of it. The other 2 are kind of watching it.
Exactly.
But you have at least 2 faculty operating that system. And this is why they might only be doing simulation a couple times a semester. It is an orchestra. It requires multiple people being paid a full-time salary to put all of this orchestra together, and it takes time. So you got a class of 40 students, they're not all doing it at the same time.
Let me jump in there. And nursing school budgets are only now really beginning to adapt to simulation. So it costs a fortune for us, and you have a nurse who's a really good clinician who now has learned to become a good educator, but now has to be able to operate a mannequin. That's asking a lot of one person. So 3 jobs in one.
And don't break it, because that mannequin is $120,000 each.
So VR is the answer, because you can do it at home in your bunny slippers, and then I can come in and do it at work, and you as the educator can see what's happening on the back end. You've got all those metrics on the backside in the system. So I know who's doing well and who's not. It's awesome.
So I interviewed a couple of educators that are actively using the system right now. These simulations are building blocks. This is the learning to walk stage, the basics. The goal is to get this piece down and take it to the next step next time. We want to give them a safe zone. You put that headset on, even if you've got spatial pass-through activated, you're in your own world. It is you, and no one else can see what you see. If you're making a mistake, it's yours to make. It's really scary to be on stage. I was nervous to come up here. I do this all the time. It scares me every time. Can you imagine if I was up here doing simulation and someone was going to die and she was over my shoulder saying, do it better, do it faster, come on, this is real life. So this is the anatomy of a siloed simulation through immersion, through spatial, through virtual reality. It starts with a pre-briefing. The learner understands what the sim's going to be before they enter, and then they're in control of when to begin. They get to decide, all right, I'm ready, let's do this. They have a moment of self-discovery. They start to learn what they know, what they don't know, and there's no embarrassment. It's just them. They get to try again at will, without fear, until they get it right. And then they can transfer this to practice. Better debriefs with the instructors. I want a student in front of me who's done 100 patient simulations, and I want to know what questions they have after that, versus a student who got to do 1 simulation per semester or 2 or 3 simulations per semester. That person's going to treat me if I get sick in the hospital. I want that person to have seen a lot of patients. I don't care that they're digital. I want them to make good clinical decisions. Because when they get in the hospital, they're going to have to learn whatever the existing infrastructure equipment is going to be. Every hospital is different. They're going to have to figure all that stuff out. But can they make the right medication dose decision? Can they make the right, it's called a differential diagnosis, where you're saying, okay, what you have could be one of 4 things. It's probably most likely this. I don't feel the need to change the sim as they go through it, as the students go through it, because I pre-designed it with a certain outcome. That's the whole idea. The students are laughing at themselves when they make mistakes. I want to do it again to see if I'm more on it this time.
And I want to say that gamification for learning decreases that cognitive load. They retain so much more of what they've learned because they know when they debrief, I can see that they maybe messed it up 4 times, but that they got it in the end, and they can tell me how they got better and better. It is so much better than what I have been doing for the last 15 years.
This person was born with a screen in their hand. This allows us to meet them where they are. You're going to stumble. It's okay to fall down. It's a safe learning environment. Go back in and try again. This gave the student a little bit of distance or psychological safety because of the headset. This technology enhances competency. It boosts confidence and in preparedness for real-world challenges. It's a transformative way to educate the next generation of nurses.
And let me say, there's always going to be more nurses on the planet than any other discipline. So although the surgeons and the physicians have more money, it's a very small concentrated group. There are a lot of nurses on the planet, and being able to train them well, there's a lot more money to be made there. So I've been here for the last 3 days. I've heard a lot about that value proposition and how are we going to get our cut. I will say that as I've looked at VR Patient, a lot of the guys in VR Patient don't have hair. And I said,
the avatars.
I said, how come your patients don't have hair? I said, when we built our game, I was talking with my developer guy. I said, how much does it cost to normally build a game? And he said, that's the wrong question. He said there are companies where they spend $50,000 on getting the eyelashes on one of the avatars correctly. We built our game for $50,000. So he said it can be millions and millions of dollars to build a game. So they're spending money where it needs to be spent. Right. Thankfully, the women that they have in VR Patient have hair.
Yeah, she's talking about a virtual game that you built a couple of years ago.
Yeah, Foley Cast.
Yeah, and so in VR Patients, the avatars, the males are bald, and it's so we can allow the users to put trauma on the skin and let them get to training and treating, and we'll make some more avatars with some hair. But really, the goal is not to make the most beautiful hair; it's to create the platform that allows them to simulate on any physiologic disease that they need to get the student to success. The goal is retention of the students. The goal is higher engagement, and it's competency.
And one of the things that's changed recently for nursing is that we're moving to competency-based education. And if somebody builds the game, the program that we will use for testing all nurses in the United States, all nurses that might be coming into the United States, that's going to be a lot of money. It's going to be awesome. And I know that some of the provinces in Canada now are bringing in a lot of nurses from the Philippines, and they have VR headsets in the Philippines to check out the competency of the nurses there before they give them licenses to fly them into Canada to practice. So this is going to happen all over the place, and competency-based education and evaluation in the U.S. is being worked on right now. I'm on a committee that's helping with that. So there is money to be made. That's what you need. And what we need is good games and good helping for us to be able to do the competency-based teaching and then evaluations that we're going to need.
And this is the power, additionally, of an asynchronous, siloed, distributed, scalable platform. When you've got nationwide or even global, international testing that needs to happen, that you need to trust once it's deployed, if a student gets 80%, they actually did the things because it was objectively graded remotely, that is power. That is a public health solution. That's different than I'm going to download a game and I'm going to run that game simulation And once I figure out how to beat it, I'm not learning anymore. I can't make changes to it, so I need to buy and download another game. That's not scalable. That's not objectively gradable and distributed. So we're going to show you a little video here, and that should leave a little bit of time. It's only 2 minutes for some questions. And this is to show you what it looks like when a student or an end user is in this type of like asynchronous siloed simulation, whether it is nursing or out of hospital. There you go. We've only got about 2.5, thanks, man. Only got 2.5 minutes left, but if you guys have any questions, those are our LinkedIn's. Feel free to connect with us. We'd be happy to have a conversation with you going forward. But yes, hi. Could you use the mic? Just because it's kind of hard for us to hear you from up here. Thanks.
Yeah, this was really fascinating.
Good.
Thank you. So I'm curious about your use of the word game. Because when I think of game, I think of something interactive, but I think of, levels and
Right. Points, leaderboards.
points. Yeah, and something that's fun. And so I'm wondering if you can define why you use the word game here.
So we typically actually don't use the word game. Occasionally we'll use the word it is gamified. But that's about as
Gamified.
far as we go. Because it's a professional platform, because it's serious gaming, right? It is serious engagement. The only reason we use the word gamified is because it ends up being virtual. You're putting on a headset, it's digital or virtual simulation. At the same time, we are still trying to meet those end users where they are. And they're used to using the word game. They want to, quote, play games when they're doing their learning and their education. And so I actually would love to ask you about, do students typically laugh and have fun when they're playing with mannequins?
Absolutely not. But what I find interesting is that when I've had these kinds of things around where I could see things happening along the way, I've had research stuff in my office. Students really get into wanting to be good at this, and they want to have the best points, and they want to have everything correct because they're used to being really good. A lot of them are real perfectionists. Probably not the best thing in healthcare from what we do in nursing. Wonderful and also causes some problems along the way because the patients a lot of times are not going to be perfect in the end. But yes, when they're practicing, they like to get a good score. So in their heads, that's games.
Yeah, what the system, what VR Operations provides is like a competency score that's set by the end user, the faculty. And then what the faculty can see is how many times were they running those sims? How much time did they spend in simulation? What are their scores? Did they hit the criticals? So they have information to sit down and talk about what they were learning and then try again or do a different one or try it for real, make it count. Yes, question in the back.
This is really interesting. Thank you for this. I'm curious, like when they're working in an ambulance, like that's obviously a very emotional, kind of chaotic environment sometimes. How do you prep them for that? There's sort of like the social skill and sort of self-regulation component of doing emergency work. Does that come up kind of in the curriculum that you're implementing with them in any way?
So I actually, I can speak to this. So I was a paramedic student, I am a paramedic, and then I became a faculty and I was teaching at the paramedic school. There is a whole component to the curriculum about, look, this isn't for everybody. And you're gonna see some really, really sad stuff, especially in emergency. You're gonna pick up all shapes and sizes, all ages. I'll never forget the first drowning of the summer when I was working in the emergency department because she was only 3 years old. Never forget her. So you usually in the curriculum, when they start their clinicals, people stay or they go. But they are prepped, and there is some like mental health discussion, and then we have what's called critical stress debriefs. Now, all of that stuff can't not be solved by virtual simulation. Virtual simulation can't do everything, and it shouldn't. We need to talk to people. We need to sit down with the wise proctors who have 25 years experience.
Right. And that's what's done in the pre-brief. They know where they're going into a stressful environment, and we talk about that, and then we debrief at the end. This isn't just a game, and then they're done, they get a score, they walk out. There's work at the beginning, and then there's a group work at the end as we talk about what's happened.
Yeah. Yeah, all the students, when they enter the sims, they know what their learning objectives are, they know what they're walking into before they start it.
And our time is up.
Oh, yes. Thank you, guys. Thank you so much.
So thank you.
Do you have a question?
I certainly do, yeah.
Well, let's hit one more.
One more. Awesome. So I have a bit of a background, 20 years working with competency-based transition to practice programs. You mentioned that what is driving this is actually changes in the way we are trying to teach and make that much more competency-based. So is this then targeting mostly academic environments? Or the idea is to also target acute care environments where there is a lot of talk, but actually it's moving in the opposite direction. A lot of these competency-based programs are being kicked out because they are not financially feasible.
Sure. You're absolutely right. Primary users are education, like universities. Secondary users are the professional environment like hospitals, and that is used for remedial education. So maybe there's a sentinel event in the hospital, something bad happened, and they all need to do some continued education around that, that patient event. And so they can do that in this way. It's very cost effective because hospitals don't have a lot of simulation space. And the ones that are connected to universities borrow the university sim space. But when you have a system that's spatial and you can see your environment, any room in your hospital, your whole hospital becomes a simulation space. And so extra time on shift can be spent doing some remedial education. And really, they've already got their license. They're professionals. So they really just need to log the time so that way the next time the Joint Commission comes in to do an audit, the hospital can show, we are training on this. We are working towards a better outcome on that, and here's how we zeroed in and laser targeted towards it.
But we still have 250,000 dead per year because of medical.
Absolutely.
Yep, medication errors are one of the
Absolutely.
biggest problems out there, absolutely. Thank you guys so much.
Thank you so much.